And good day to everyone. Welcome to episode number 213 of the Crisis Jam. I'm Dr. Brian Sims, Senior Medical Advisor with the National Association of State Mental Health Program Directors, and I want to welcome you to this Crisis Jam for episode 213. Today we have an absolutely fascinating and wonderful debate that is scheduled. We're going to have Justin Chase on the affirmative and Preston on the negative, and it's going to be about mobile crisis and whether it should be dispatched by the local 988. So exciting that we're going to be going through this. It will be moderated by Erica Chestnut Ramirez. So we're really looking forward to that coming through today. So I do want to remind you all that we have had roughly about 520 unique speakers, and they are all listed, and this is since 2020. And it really is a kind of call out to say that we also want your ideas. Bring them, place them in the chat. You'll see the link in there where you're able to pull up that information. So help us out here and see if we can get some great ideas and maybe even double that number. I do want to point out also about talk.crisisnow.com about looking into that site, because we have been using your, say, government assigned Zoom or otherwise, but we wanted to make sure that you were aware that it's been expanded now to where you can access it through YouTube and you can access it through live streaming. So there's a lot of information that can be acquired through either of those measures, whatever you're comfortable with. And we're seeing a lot of people come on board with the live streaming. You'll also see within that a wealth of information for those of you that have not yet registered, a link where you can go in and register. It is free, but again, you just have to ensure that your Zoom line is established so that we can send you out weekly links so that you can get into the Crisis Jam. Also, within that same site, you'll see things like our fireside chat with the Guardian of the Golden Gate Bridge, which is an absolutely phenomenal presentation done by Kevin, and he was just so spectacular with it. So you'll see that and a host of other information with trivia hot seats and other information that has been on there before. And I had mentioned earlier about the YouTube components, to take a look at that particular element, because again, it's new and it's been loaded now with tons of very useful information that if you are looking at any particular topics that you may have missed out on, it's great space to go into to take a look at. Now, we have been doing debates and we're scheduled to do a debate today, and it is just a phenomenal, phenomenal opportunity here, because what we are looking at in the debates is, in this case, should mobile crisis be dispatched by the local 988? So what we're going to do today is actually work on a pre-survey. So we'll put up a poll and just look at the question, should mobile crisis be dispatched by the local 988? And here's your pre-survey responses. If you'll place your response in there, please, and submit it. We'd like to get a response from everyone about this particular question. Mobile crisis should always be dispatched by the local 988. And what we're going to do is poll together all of that information. We're not going to show you the results just yet, but we want to make sure that everyone gets an opportunity to submit your answer. And while that is being polled, we're going to go ahead and move on to take a look at some upcoming debates, because we've already talked about a debate that is going to take place today. But I want to also make you aware of debates that are upcoming. On May 14th, we're going to have another debate. And this debate, it will be about all states should enact legislation that includes a 988 fee. And we'll have Hannah Weslowski and Tom Betlock looking at the affirmative and the negative on that. And we want to make sure that people understand it's not necessarily negative, it's another opinion, it's another reflection on it. So it's not always about the exact opposite. Looking again up to June 18th, crisis facilities should require patients or parents, to stay during a crisis episode. Again, we have Gwenda Summers for the affirmative, and we have yet to get someone for that spot for the negative or the other opinion. But that will be episode 222 of this particular debate series. The other thing that we've been doing, and you've been seeing a lot, are these live and on location, just wonderful ways of just changing the format of the experiences for crisis intervention services. And we're looking up to taking a look at all of those pieces because we're trying to get all of the core services of crisis intervention on video and on location, so you get an opportunity to see it actually in action. Now, I want to point out also, coming up on June 4th, there's going to be an issue with live and on location at the ADAMH Board of Franklin County. And this is going to be another opportunity to take a look at one of the spectacular facilities that are opening to provide crisis intervention services, where you can see from the screen there, over 72,000 square feet with 60 recliners, 16 inpatients, really moving forward and moving that needle. Do want to point out on the crisis news, there was a recent article released from the Governor Youngkin about the Right Help Right Now program that lists the 6 pillars. And you see those pillars there, just something that you would need to reference because there is a lot of work going on in the 988 realm. And this is just some good work that is pushing that needle forward. Now, next, we're going to go to an over-under. And on this particular over-under, we're going to kind of do it in a duplicate fashion. We're going to do one and then we'll move right into the other. But in order to do this, I'm going to call on David Covington. Dave, you come on in, man. Let's get this thing started.
Thank you so much, Dr. Sims. I loved the Virginia phrase, right help right now. And we're going to do a little preamble. I first started working with mobile crisis and a crisis call line in 2002 in the city of Atlanta. And the mobile crisis service was right in the building where it says Jesus Saves there at the top, just south of downtown Atlanta there. And at that time, the crisis call line did not dispatch mobile crisis. You had to fax a referral to the mobile crisis team, who would get together and have a staffing. And they would then look at and review that dispatch and determine whether they would or would not go out on that mobile crisis referral. And sometimes they determined that they would answer that over the phone instead of which was always very frustrating from our vantage point as the crisis line. We had determined the person needed a mobile crisis. So that right help right now was challenging that in that environment. But I want to lay out a couple of over-unders, Brian. And first, that was in the state of Georgia. Let's move to the state of Arizona and some interesting data just to give a sense of what volumes can be. This is the 2016 and 2018 total mobile crisis dispatches in Arizona, 26,000 and 28,000. If you straight lined that, just did the math on what you would expect, we would have had 35,000 mobile crisis dispatches if it grew at the same rate in 2024. Now, we did see in COVID, some mobile team actually went down because of not going out in person and shifting to virtual and concerned about safety. So the first question is over under. Was the actual 2024 volume higher than projected or lower? Was it 35,000 and above, or was it below that? So actually, if you just write into the text, into the chat, was that over or under? Let's see what our audience thinks. And we've got people all over the board here as we jump around. Striking increase, 45,000, almost 46,000. Justin, we'll get into the dispatching of that as Solari does that, but that's a heavy volume daily that's going on through that. Now, Preston's going to take the negative today, but he and Matthew Goldman did a national survey where they put forth 988 integration as a best practice. And they asked, how often does this occur? So let's look at dispatch in other environments. How often is an ambulance dispatched by 911 versus some other means? Well, the vast majority of the time, 90 to 95%, you get an ambulance by calling 911. What about fire? What percentage of the time does fire come through 911? I would have thought it was 100. It's not quite 100. It's actually 89. So there are some unique situations where you get an ambulance or fire some other way, but by and large, that comes through 911. So the question then is, how often is mobile crisis dispatched by 988 versus some other means? So our over under here is just put your best guess into the chat. It happens 95% of the time that 911 is the way that you get to fire or ambulance. How often is 988 the way you get to mobile crisis teams? And we've got 23 and 40 and 25. I'm gonna let a couple of answers go through. So Ralph, with your 33.3, that's going to be our winner 32% of the time. So about 1 in 3 times in the US where mobile crisis teams exist, you get that through 988. And back to you, Brian.
Thank you so much, David. And thank you all for putting your things into the chat. It's really helpful and really educational. We're going to now move to our debate for this morning. And today's debate, again, mobile crisis should always be dispatched by a local 988. And we have the pleasure of having a moderator for this. And our moderator is Erica Chestnut Ramirez. And without further ado, I'm going to turn it over to you, Erica. Take it from here.
Thank you, Dr. Sims. Good morning to everybody who's on the West Coast, and good afternoon, I can say now, to those who are over on the East Coast. Thanks for joining today. This is going to be the 6th debate in the Crisis Jam, and I have the pleasure of being your moderator today. Again, my name is Erica Chestnut Ramirez, and I'm the Regional Vice President for La Frontera, Arizona, and I oversee everything within the central region of Arizona, and that includes MPACT Suicide Prevention Center. MPACT is a longstanding mobile crisis provider, and we are the largest in the state of Arizona. And I've even been told maybe even the largest or one of the largest in the entire country. So I am pleased to bring this topic that mobile crisis should always be dispatched by the local 988 centers. We have the pleasure of Justin Chase and Preston Looper today. I'm going to push it to Justin first to talk about the proponent of this debate. Go ahead, Justin.
Thank you, Erica. We talk about the affirmative here. To ensure the most effective, compassionate, and safe response to mental health crises, mobile crisis teams should always be dispatched through 988 or crisis call centers rather than through self-dispatch or 911. Crisis call centers are specifically designated to assess and manage behavioral health emergencies, ensuring that the right level of care is provided while minimizing risks associated with law enforcement involvement or resource misallocation. I identified 5 key reasons to justify 988 to manage dispatch of mobile crisis teams. First is to ensure proper triage and crisis assessments. 988 call centers are staffed by trained mental health professionals who can de-escalate situations over the phone, text, or chat, provide guidance, and determine whether a mobile crisis team dispatch is clinically necessary. Self-dispatching typically lacks an initial triage process, leading to potential inefficiencies and potential overuse or underuse of mobile crisis teams. For 911 dispatching, operators, while trained in emergency response, may not be mental health professionals and may misclassify mental health crises, leading to inappropriate responses. Second is reducing unnecessary law enforcement involvement. While 911 dispatches mobile crisis teams, police officers are often included by default, increasing the likelihood of escalation, use of force scenarios, or unnecessary hospitalizations. 988 prioritizes healthcare-based responses, ensuring individuals receive treatment rather than face potential criminalization. Many communities, particularly marginalized populations, fear police involvement and may avoid calling for help if they believe law enforcement will be dispatched. Third is improving efficiency and resource allocation. Self-dispatching mobile crisis can result in inefficient resource distribution, with teams responding to cases that might be better addressed through telehealth or an alternative crisis intervention. 988 call centers have centralized coordination, allowing them to prioritize high-risk cases and direct teams to where they are most needed. 911 dispatchers are trained to respond to life-threatening emergencies, but they may not have the capacity to determine the best mental health response, leading to resource misallocation. Fourth is enhancing crisis response coordination and follow-up care. 988 is designed to integrate crisis intervention with ongoing mental health services, ensuring that individuals receive continued support after a mobile crisis response. Self-dispatch teams may not have access to caller history, prior interventions, or mental health service referrals, limiting their effectiveness. 911 dispatching of mobile crisis often results in a disconnected response with limited follow-up or linkage to ongoing behavioral health services. And fifth is really building public trust in crisis services. Many individuals hesitate to dial 911 for mental health crises due to fear of involuntary hospitalization, police presence, or other punitive measures. A consistent healthcare-first approach via 988 encourages people to seek help sooner, reducing the severity of crises and preventing unnecessary escalation. And finally, a standardized dispatch system through crisis call centers ensures predictable and compassionate responses, fostering community trust. And with that, I'll return to Erica.
Wow, Justin, you still had 1 minute and 30 seconds left. You got that through record time. So thank you for that. I appreciate it. Preston, let's hear your thoughts. You get in 5 minutes now.
Yeah, nicely done, Justin. And I think, it sounds good, and it seems like a simple idea, but there's lack of industry consensus regarding what is even meant by dispatch. And, is it a negotiated referral, or is it you say I go, or my favorite saying is if it rings, we roll. There's a lot of contingencies there. What is the workflow and the protocol for dispatch for a 2-person team versus a solo responder? What scenarios are appropriate for mobile crisis? And, Justin, when you were talking, you framed it as much of this has already been figured out. And that's not my experience from working around the country. There's quite a bit of variability in these. How will the crisis line frame and screen for suicide, violence, weapons, guns, in particular, guns in possession or play, medical emergencies, etc.? And then what are the scenarios where mobile crisis would be prioritized versus only referred after the hotline has failed to engage? A lot of people, and I'm with them, believe that kids and families we should gather the information, but there's certain scenarios where an in-person response is just much better. And then finally, how is mobile crisis being pitched within a readiness to change framework? And, Justin, like you, I've listened to a lot of calls, and there's a high degree of variability around these sort of issues. So to suggest that standardization is the rule, I would disagree. The other issue is that 988 dispatch to mobile crisis is a classic integration play. And I can tell you from my perspective, across the country, we're not ready, and we need a bigger boat. Many hotlines and mobile crisis teams aren't ready in terms of an engine that's a digital workflow, documentation, analytics engine. And, a lot of the tech is clunky and doesn't work really good. And it's a piece of middleware, and there's an additional step that's going on. And sometimes they're not even that secure. And there's some mobile crisis teams, not all of them, that have good tech and really have this wired. And, are you going to use my tech? Am I going to use your tech? I worry that mobile crisis will get the short end of the stick in many of those interactions. In addition to that, and here's a place where I, just directly disagree, is that many mobile crisis teams, in fact, the majority, we know that only 32% have integration. So they're all, a big bunch of them are doing self-dispatch. And many times the there's a super user assigned to managing referrals and orchestrating service delivery across multiple lines of business. And I think this is really important, is mobile crisis teams, in order to survive, often will do mobile crisis. They'll also have do ED or psych ED response. They may respond to jails, and certainly 988 handling those doesn't make any sense. And my sense is there's a lot to learn from these super users who've been doing this work. In addition to that, 988 taking over the dispatch, and my prediction would likely lead to reduced funding, taking away that critical resource where you have a super user orchestrating the delivery of what typically are small mobile crisis teams. In fact, Justin, as you may recall from looking at the survey, there's the majority of mobile crisis teams have under 12 FTEs. So by definition, most of them are small and fragile. And the other is many mobile crisis teams are too small to be an on-demand solution for an external agency. They're just not big enough. They're not yet ready to adopt a if it rings, we roll perspective. I've experienced mobile crisis dispatch from the hotline when the hotline and the MCOT and the mobile crisis are the same organization with shared staffing versus separate organizations. And I'll tell you from my experience, when it's a lot easier to get everybody on the same page, and when there's integration within the same organization, you have adequate capacity, great tech, assigned super users processing the case assignment and dispatch, shared values, shared clinical operational protocols, shared training, shared CQI, that just works better. When you have these silos, it takes a long time to get everybody on the same page. Otherwise, already fragile mobile crisis teams will be adversely impacted, as in my experience, many payers are in a ready, fire, aim perspective, as opposed to being patient and taking the time, leveraging implementation science best practices to pull this together. Again, this seems simple, but it is deceptively complex. Thanks, Erica.
Thank you, Preston. That's great. So if you have questions for our participants, please put them in the chat. I do have a few questions that I've kind of prepared. Justin, Preston was talking about some areas, and I've seen in the chat, there are some states that are not prepared for that type of dispatch of mobile crisis that is super sophisticated in terms of knowing where the mobile teams are, being able to dispatch them. Can you talk a little bit about that and how that could affect mobile dispatch?
Absolutely. I think for me, and I appreciate Preston and the comments. The question here is whether it should be, whether or not it can or has the capacity right now. I think this should be our true north. This should be our target in the direction that we're heading as an industry. And without pressure from policymakers, from payers, from other entities, I think we're missing a huge opportunity to set the target of where we want to land and put the things in place to get there. And so I don't think it's a has to be ready today. I think it's something we can target over time and move in that direction. So I think there's naturally a progression, and abandoning it now because we don't currently have the capacity, I think is missing the mark. So I think there's huge opportunities for it, us to set a true north and move in that direction.
Very good, Justin. Thank you. Preston, do you have any comments after Justin went related to my question?
No, I like that idea in terms of it seems that there may be some sensitivity to unreadiness, and really looking at prioritizing resources to enhancing readiness so the implementation isn't adversely impactful. And so for me, I'm in a place where, of course, I'm worried. Worried about all the stakeholders, the consumers. I've got a special place in my heart for the mobile crisis teams who've been out there slugging it away for a really long time, and just hoisting something upon them can be decimating to fragile organizations that already have workforce challenges. And so I've seen this done clunky and poorly, and the amount of friction can be surprising.
Good point. Thank you, Preston. Yeah, when I think about this, I like Justin's comment of that's our true north, so to speak, right? So, and to Preston's comment about seeing it both ways, I will say that also as a provider of a call center as well, because we do have, we're part of the Vibrant subnetworks for 988. We've also have private contracts which respond to tribal nations. And so we dispatch our own mobile crisis as well because we have private contracts. So I've seen it both ways. We do it both ways. We have our Arizona public mental health that are dispatched through Solari, and then we have our private contracts as well. And it's really to meet those cultural needs. So I can see it both ways too. You guys have great points. I did see a question in the chat that I wanted to put to you all. So Jerry Hall put in the chat, how do we prevent designing what is effectively a single funnel most current emergency calls must pass through, like 911, which seems to inherently allow bias to slip in and take hold. When working with individuals in unique mental health crisis, how do we avoid that? Preston, do you want to take that one first?
Wow, that's a great question. I think in terms of for me, the issue is how can you design in transparency and accountability from jump in terms of your analytics, in terms of looking at racial disparities, gender disparities, sort of a number of things, so that from my perspective, I would take we need to think about a data dashboard that's both sort of quantitative and qualitative to manage that issue. But yeah, when all your eggs are in one basket, it can be problematic if that basket holder has the significant biases or problems.
Justin?
Yeah, I think from a way to combat this is really about bringing the we together of collective decision-making and building processes and partnerships. We do a lot of work with 911 co-location and diversion efforts to really be able to curb this. And it really is not about supplanting and putting a call taker in the 911 center to take the calls. It is how do we influence behavior and change and really tackle things like stigma and bias in a collective effort. We have a lot of individuals that contact the crisis lines through 988 or other channels that are also familiar voices with 911. And so how do we work collaboratively to provide a more holistic approach and wraparound? So there's not necessarily a one solution, but I think there's ways that we don't want to turn down this no wrong door approach, but how do we work collectively to provide the most ideal care in the right moment in the right way?
Great point. Great point. And it sounds like from what you're saying too, that the speed to be able to make sure that we have the ability to dispatch quickly and be able to get mobile crisis teams on the road is super important. Justin, can you talk just a little bit about that piece before we move to our roundtable?
Yeah, I think part of why you want to see a centralized process for dispatch is not just from the qualitative aspect, but managing volume and capacity. It is very difficult to be a contact center operator and a clinician working with an individual or family and not knowing whether a mobile team is available. Or what I see frequently, unfortunately, is we have to then contact the mobile crisis team who then wants to triage themselves and determine whether or not they're willing to go or not. That really breaks down the clinical trust and the relationship that the call taker has been having. It really is a demoralizing impact on the crisis line's ability to provide resources. If I'm the the call taker say, you know what, I think a mobile crisis team is justified in this situation, would be the best practice. And I go to dispatch a mobile team, they're like, you know what, we're not going to go for whatever reason. That really breaks down that trust in the system. And so I think that can really be problematic.
Makes a lot of sense. So we're going to give you each 1 to 2 more minutes to talk just your final comments before we move to the roundtable. So Preston, you get to go first, and I'll give you your time.
Well, I'll tell you, I really appreciated the way that this went down, in terms of a recognition that there's a lot of work on the implementation side of the house as opposed to a ready fire aim. And I think, I may be a little bit nitpicky. I think Justin might have been a little overzealous talking about capacity. And I think the one issue is, at some level, and I just want to follow up with Justin's point, is, it's hard to be a crisis line worker and do this. And so for me, the issue is there an additional mobile crisis dispatch capacity that's built in? And is that held by mobile crisis and the hotline, or just held by the hotline? And so I think that there's that. And then this other issue is, how does a mobile crisis team who already has self-dispatch, who's orchestrating across multiple lines of business, how does that work together? And then finally, we need better tech. There's some tech that's out there that's lightweight. Most of it is middleware. And what's really lacking is a digital engine that's workflow documentation for both hotline and mobile crisis. And so I'll pause there. Thanks so much.
Justin, your final thoughts?
Yeah, I think, and again, all great points by Preston. And again, to me, it's whether it should versus whether it could at the moment. I think, in my opinion, dispatching mobile crisis teams through 988 or crisis call center is the most effective way to ensure proper triage, the most appropriate response, and long-term connection for care coordination. Unlike self-dispatch or 911, crisis call centers provide specialized expertise, work to minimize law enforcement involvement, optimize resource use, and build trust in the behavioral health system. By centralizing mobile crisis deployments through 988, we create a system that not only makes the work more efficient, but also safer and more compassionate for those in crisis.
Thank you for your closing statements to both of you. Now we're going to go to our round table. So we're going to bring in 2 additional people. So we have Becky Stoll and Megan Gleason. And we're going to give each of them just a few minutes to reflect on what's been talked about during the debate and give their thoughts. So Becky, do you want to go first?
Sure thing. So I made notes and was listening intently because I knew what my thoughts about this were, and wanted to make sure I was, cognizant of the 2 esteemed colleagues who duked it out. It made me think of when you could play the Wii and you could box, and I was waiting for one of them to come and stand over the other one and flash their arms. I would call it a draw. I think where I've always sat with this, Preston just got to it at the very end there. To me, it's very different when you talk about dispatching mobile crisis and taking crisis calls. Those are 2 very distinct activities that crisis call centers engage in. And I think we need to delineate that. All the things that Justin was talking about, the proper triage and unnecessary law enforcement and efficiencies and all those things, I think are 100% true, and we don't want to give that up. But the dispatching of mobile crisis can almost, and I don't want to see people freak out in the chat, it almost can be an admin function. To me, you don't need the same skill set and competencies to handle crisis calls or chats or texts as you do to dispatch mobile, keep up with mobile, and be a good partner and eyes and ears for those people that are on the ground. So, like internal to our system here at Centerstone, a few years ago, we did exactly that because I operate multiple 988 centers and I also operate non 988 crisis call centers. And we were taking up so much time of people that we were looking to have a certain competency and skill level more on the clinical and peer support side that it really dawned on us, why are we having them be the dispatchers of mobile crisis? I need people who dispatch mobile crisis to have great customer service, great attention to detail, and be able to look at the totality of where and who are going out to that. So my advocacy is that we look at this as two different roles, that they are not singular, and that we approach the work. I agree with Justin. We have a lot of work to do. I would love to see more centralization of the dispatch function on its own, and that they have the skill set they need to have. And whether we get to a point where that would be in my mind a really long time. If that's our North Star, it's going to take a hot minute to get there, because there are so many other crisis lines. And we also have to remember the system's not very mature yet. I know we like to compare it a lot to 911, but that's often an unfair comparison because we're not mature yet. So I'm waving the let's do this flag, and have people that have the skill sets to do the jobs and not blur those.
Okay. Thank you, Becky. And, to your point too, I think in Arizona, we have our crisis specialists who answer the phones and who are doing the clinical intervention, and then they're able to then pass off to a dispatcher to be able to see, so I think that's great. So Megan, you are up.
Yeah, so lots of good discussion here for sure. And, operating a mobile crisis program for many years in the state of Georgia, and being that we have definitely been dispatched through the 988 center, I see both points. And I really feel like this integrated concept of actually being able to talk and look, Justin, when you talked about the assessment piece, and the struggle with providers assessing differently, and the almost fragmented part of our system between mobile and our 988 centers. And I really do feel like there needs to be a more collaborative approach. I think dispatching is an entity in itself, but I do think it is an essential part to having mobile dispatch and that continuity of care throughout the crisis system coming from that 988 center. I think a very much a central approach is really where our system does need to go. It provides the people in crisis with that support and consistency, because they do not understand how the system is broken down. And that creates a lot of fear and concern among providers, but also among the families and individuals in crisis themselves. And in Georgia here, we also service with our IDD population, which also encompasses a whole different component there too, an assessment from our 988 centers, and also as we work to integrate with our mobile teams who are directly in that field. But there needs to be a more coordinated connection between the two systems, as right now I think across the country it's just very fragmented, and it doesn't give a lot of confidence to the people who actually are in crisis that we're trying to serve.
Thank you, Megan. And to that point, when we were looking at the over under that we did previously when we looked at the numbers for the state of Arizona and how they just completely skyrocketed beyond what we truly thought. You know, there was a lot of work done, obviously, within that time frame, the 2020 to 2024. We had the bringing on of 988, right? And Solari did great work in working with the 911 centers, having folks who are housed within the 911 PSAPs to be able to make sure that they could identify, you know, mental health calls and then push them to the mental health 988 system to be able to dispatch mobile crisis for those folks. So, you know, we really did see that huge increase. Now, Preston, you had the job for us of, you know, really kind of taking the antagonist piece here. And so I wanted to bring you back so that you could have a final comment related to the debate.
Yeah, I really appreciate the opportunity, and I hope people walk away seeing my content as yes on vision, but there are some deets that got to be attended to, integrated care plays, and I know this is both within behavioral health, but if you just look at behavioral medical integration, those sorts of things, or integration within 911, it's really important that we're thoughtful and do it well. I think there's a lot of us that have the ability to help. But just pulling the trigger on something really simple, saying we're going to do it and we'll work out the details later, that won't work.
Yeah, I really like the graphic of we need a bigger boat, right? There's a lot of work that still needs to be done. I like the idea of it being our true north, and that's where we need to move towards. We're just not everybody is there yet. I think, you know, just looking through all the comments in the chat, seeing where other states are with this process and where we're moving towards. So I appreciate everyone. Thank you so much to our roundtable participants as well as our debaters. Thank you, Preston. Thank you, Justin, Becky, and Megan. I'm going to push it back over to
Nice job, Justin.
Well, can I just say this before you bring it back to me? I've also been looking in the chat box, and I'm very curious about the response to a particular question. So Preston, Justin, and even Erica, if you guys want to hang around for it, there was a question in there that talked about looking at the mobile crisis response in very rural areas with wide distances between communities. Any comments on that? Any thoughts or ideas about how you would take it? What he says is, from a former state perspective, mobile crisis treatment operation is greatly impacted by very low population density where they are and great distances between communities. So they're asking, how do you see it in states like Wyoming?
Yeah, I'll take first whack at it if you don't mind, Brian.
Sure.
I think that and I've got a special place in my heart for rural America. Grew up in rural America, done a lot of work in rural America, in particular mobile crisis. And I think it gets to, we were talking about this issue of, is the hotline the same organization, or are they silos? I think in rural mobile crisis, well, I think there's a couple of issues, and one is that's really tricky. The current draft version of the mobile crisis toolkit is a little oblique as it relates to 2-3 person team or solo provider. So that becomes an issue. And so I think in rural America, mobile crisis teams are going to need to figure out partnering with other persons in networks. And so, for example, I know some people are concerned about EMS. For me, EMS being involved, you're not sending a gun to a healthcare party. So I like that, whether it's community paramedicine or EMS, or there may be receiving facilities. I think that you've got to look at what's the way to integrate. Sometimes payers are worried about putting all their eggs in one basket, but I'll come back, and it's one of David's favorite of my comments is scale matters. Crisis services are hard to provide if you're not big enough and you don't have backfill and redundancy. And so those rural communities, you've got to figure out how to partner to create that and still avoid sending, armed responders or responders with guns unnecessarily.
Justin, any comments?
Yeah, it really requires creativity and thinking out of the box. We talk about, rural, frontier, tribal communities as well. We have to get creative in Arizona with, we have a tribe at the bottom of the Grand Canyon that we have to coordinate how to get a mobile team down there. And we have to helicopter them in or bring them in by mule. We have to really be creative in those ways. Oklahoma's done some really neat things with partnering with the CCBHCs within the community to provide an on-call model versus a dedicated mobile team. And then we just have to think out of the box. Do we have areas that have limited connectivity? How do we get the documentation, the information to, so are we going over radio versus cell coverage where we have limited accessibility? And so really having to think out of the box, partnering with EMS. And there are times we got to partner with law enforcement. If we're not able to get a team out there timely, how do we, again, think about it? It's been hard to figure out. And again, I think it's an individual community level. Each one is so different. But.
Wow.
I've got one final comment on this, Brian, if you don't mind. I know that funding is an issue, but it's kind of like, how kid services are just more expensive because you have more consumers. If you see a kid, you're apt to have multiple consumers versus an adult. You might have just an individual. Same for rural services. Rural mobile crisis is more expensive. Full stop.
Wow. Well, to all of you, this has just been a very comprehensive but very fascinating debate, and we'll kind of put debate in italics. From the comments that are placed in the chat box, there are a lot of responses. People are very invested in the both of you, and I would say to all three of you, just wonderful job, guys. Thank you so much for all that you're doing, but also being a part of this particular debate as we move this needle forward on 988 as it pertains to mobile crisis teams. So thank you all once again. We're now going to move to the post-survey. Now, you've all done the pre-survey before, same question. So we're looking at mobile crisis should always be dispatched by local 988. You have heard responses from both ends and the comments and so forth. So we're going to ask again, what would be your response as given now? We'll post the poll for you all to vote. And what we will do is, as we move forward, we'll take a look at the data that comes from this and be able to share it with you at another time. And I don't know if you want to post the poll or if you want them to respond in the chat box. But maybe what we can do is once we get that particular portion worked out, what I could do is just go ahead to move to our next segment and then we'll come back to it. So
We'll come back, Brian. We're working on it.
Great, no problem. Thank you. So we'll move then to the NASPID update. And we have with us our CEO, Dr. Brian Hepburn, who will give us some comments on NASPID.
Thank you, Brian. And just as a reminder to everybody, NASPID, the National Association of State Mental Health Program Directors, we work with states and territories. We're non-political. We focus on the continuum of care. And since about 2015, we've really been focused on trying to keep people in the community and moved into crisis services and then 988 in crisis services. All states and territories are currently focused on 988 and crisis services. but also the prevention of crisis and recovery from crisis. So going back to the debate, it was an excellent debate. Thank you to Erica and to Justin and to Preston. Our issue is the current system is not working. The more we stick to this system being close to the current system, the longer it's going to take us to basically fix the system. How is the system broken? Well, every state, I shouldn't say every state, almost every state is dealing with people with mental illness, people with substance use disorder, going to jail, being referred to state hospitals for competency evaluations. Big waste of time, not therapeutic, big waste of money. The current system isn't working. We need to make dramatic changes. That the answer to that is really moving our system so that it's more of a 988 dispatched type system, 988 being in control. Otherwise, we're going to have a system that continues to be broken with no chance of improvement. What's the big problem of states right now? Sustainability of funding. They're worried about how they use federal dollars, state dollars, local dollars to improve their system. With so much money going towards jails, hospitalization that's not necessary, it's real important to look at the overall context of what states are dealing with, what's costing. Keeping people in the community is a lot cheaper. We need to move towards an efficient 988 system. So I enjoyed the debate, but I think we really need to shake up the system and try to be true to a model, and that's trying to use the 988. From there, let me depart a little bit and just say how much we appreciate SAMHSA and all of you who are supporting the 988 JAM. The content is fantastic. This learning community is the best that I've seen. It's fantastic. I really want to thank David Covington and the RI team, and hope all of you will continue to support the importance of this learning collaborative. We have one announcement, and I think Day is going to put that in the chat, and that is that the SMI TTAC has an upcoming 4-part learning series on co-occurring SUDs and SMI. With that, thank you very much, and I'll return it to Dr. Sims.
And thank you, Dr. Hepburn, as always, and thank you for your leadership, but also the wonderful points that are made, because I think, as you can see from the chat boxes, a lot of amens and a lot of agreements in that regard. And it just shows how vested people are in making this a sustainable, successful endeavor, because it is about helping others. So thank you so much, Dr. Hepburn. And we're now going to move to our federal updates, and we have with us Sarah Corcoran. And Sarah, you can take it.
Dr. Sims. We can go to the next slide. Got a few quick updates. First, we are in the midst of the first week of a 2-week recess here in Washington, D.C., where members of Congress are back in their districts. So these are mostly updates from things that have happened in the last week or so. At the beginning of this month, on nominations update, Dr. Mehmet Oz was confirmed to lead the Centers for Medicare and Medicaid Services as the administrator in that role on April 3rd. And then to kind of switch to the more budget and appropriations updates, which is the bulk of the updates that I have today. We are in the midst of the FY26 appropriations process currently, since the rest of the FY25 process was wrapped up mid last month. So if you are working with any members of Congress, putting in requests for things such as 988, now is the time to do that through their individual websites. And then kind of more on the budget side of the appropriations and budget conversation, right before the recess began towards the end of last week, the House adopted the Senate budget resolution, which is basically an overarching framework for how larger buckets of items should be funded within kind of the individual committees for the upcoming fiscal year. This does not include things like this much for 988 or this much for mobile crisis from the federal government's perspective. This is a more kind of overarching framework document. Why I am flagging this to everybody is because it formally begins the process that they can use on Capitol Hill called budget reconciliation, which we've probably all seen quite a bit coming up about potential Medicaid cuts that are being considered. That would be through this budget reconciliation process, which basically allows the federal government under certain circumstances to consider making changes to the budget through this process, which then lowers the vote threshold to a kind of simple majority passage. That's a little bit too in the weeds for what I was intending to get to, but basically I'm sharing all this to say is at this point, they have agreed on a budget framework between the House and Senate, but that is it as of now. So when they come back in a couple of weeks, we should have some more information about how things are shaping up on the Hill, what's being considered, any potential cuts or changes that are on the table. But as of now, nothing has gone into effect, but just kind of wanted to clear where we are at this point and that there will be more to come as we get further down that process. But that is all that I have for today. And I'll answer any questions in the chat as well.
There are two things. One, thank you so much for the report. It is highly looked forward to, as you can well tell. There's been a lot of curiosity about what's going on from week to week. And while we don't have a lot of answers sometimes, it is good to at least have some information available so that we know which direction to move. So thank you so much for that, particularly as it pertains to looking at budget reconciliation, because to be honest with you, I've been on this earth for 70-some years. I do not understand what budget reconciliation is all about, but clearly you are making it much easier to understand at least where it's going and what it's all about. So thank you so much. I think if you look in the chat box, as you've already offered things, there's a lot of comments and interest level based on what you've already talked about. So we're looking forward to the next couple of weeks when you come back to us and let us know what's happening in the updates. So thanks again, Sarah. Appreciate it so much. Now, again, I just want to go back and Dave Covington put such a wonderful note in the chat box. I'd like to reference it, where he's giving thanks to Justin and Preston and Erica because the debate was not only fascinating, interesting, but also comprehensive. Because when we're dealing with this particular topic, should it be dispatched? It is such a huge issue for many states, as you see in the chat box, because people are at different levels. There are some states that are in it and in it fully, and there are others that are still seeking responses and answers as to how they may be able to open it up. So I'm really thankful to all of you, to Justin, Preston, Erica, and to all of those who gave Megan and Becky with regards to comments in the roundtable. It really helped us to pull everything together so that we're better able to see what steps we need to take moving forward. So thank you all for that. As we move forward now, we are getting prepared for our upcoming sessions. And again, after today's debate, I'm just going to give you a little bit of a teaser. And that is that I get the distinct pleasure not only of being the host for this debate, but I'm also the host for the next debate that'll be coming up. But before that, just want to make you aware of what's happening next week. We have Deaf Leads video phone services for crisis care, and our own Megan Haupt will be hosting that. In particular, I would look forward to all of you attending that particular one because it is going to be absolutely wonderful. And if we move even in 2 weeks, looking at episode 215, we're talking about a fireside chat, Real Men and Suicide. And this is given by Eric Hipple. And many of you sports fans know Eric Hipple, great quarterback. And his book, Real Men Do Cry, is going to be featured in there. So it's going to be something that, again, you have a lot to look forward to. I've heard him speak before, and he is absolutely phenomenal. But I was given some information about him a little earlier. I don't really recall the game, but apparently he completely destroyed the other team in terms of the number of touchdowns that were scored on that particular game. So a lot to look forward to, folks. So with that, I am going to say again, thank you to each and every one of those participants that were here in the jam today. Special thanks again to Erica for moderating it. I also want to thank Justin Chase and Preston Looper for being so willing and so nice about connecting up with that. And the responses from Megan and Becky are also appreciated. So to each of you, have a pleasant rest of your day. Thanks again for joining us on this Crisis Jam. See you next time.